Welcome to the webinar on ECG Challenge Competition of JACC Case Report. I'm Antonio Sorgente. I'm a section head of cardiac electrophysiology at Epicura Medical Center in Ornu, Belgium, and I'm associate editor of JACC Case Report. On behalf of the editor-in-chief, Giulia Grapsa, I would like to introduce our special guest, Dr. and Professor Pedro Brugada, who actually has been my mentor and who has a tremendous experience in electrocardiography. So Pedro, welcome to our webinar.
Thank you very much, Antonio. It's a real pleasure to be here.
Thank you very much. And we'll actually go ahead with the presentation of the three cases, which were actually the winners of this competition. So that the authors of the cases are Dr. Jeffrey Smietana, who comes from the electrophysiological section at the hospital of University Hospital, Pennsylvania in Philadelphia. Dr. Marco Bergonti from the Department of Cardiology at the University Hospital in Antwerp and affiliated also with the University of Milan, Italy. And Dr. Inbar Raber from the Division of Cardiology, Department of Medicine at Beth Israel Deaconess Medical Center in Boston. So welcome everybody. It's a great pleasure. I would like just to say a few words about, what was actually the meaning of this ECG challenge competition. We know, that training in cardiology starts from electrocardiography, and this is why, I thought about electrocardiograms as a possible competition, and also why electrocardiograms sometimes can get, the connection between younger and older cardiologists a little bit more tighter. And actually is a great opportunity to learn the basic of cardiologists, but it's very common to find in the electrocardiogram many features that can really change the life of people. And Professor Brugada is actually an example of what actually the power of electrocardiography. And so my idea was to favor the publication of those cases that were actually or very original or who could give a high deducted value. And so, I would like to introduce the first author, the first winner, who will be the presentation. So, welcome, Dr. Marco Bergonti. So, if you want, you can, share with us the slides about your case.
Okay. So, good evening, everybody. I am Marco Bergonti. I'm a cardiology resident at the University of Milan in Italy and an EP fellow at the University Hospital of Antwerp in Belgium. It's for me a great pleasure and an honor to be here this evening. So I will start right away with my case. My case is about a 19 years old female which was hospitalized due to hemorrhagic stroke. Her past medical history was absolutely unremarkable, as well as her family history, and her basal ECG was normal. In order to lower intracranial pressure, she was given propofol at a very high dose, 4 milligrams per kilo per hour, and this was associated with cooling therapies. In order to sustain systemic blood pressure, she was also given norepinephrine. Our cardiological history actually began on day 7 of hospitalization when we are called for consultation by our anesthesiologic colleague because he just noted at the ECG monitor a wide complex rhythm. So we, of course, ask for a 12-lead ECG, and that's what we see. So there is actually sinus rhythm at 104 beats per minute. The QRS is actually narrow, as we can appreciate in V1 and V2, and it's fused with a giant T wave. In the middle, there is an elevation of the J point and the ST segment. So this whole pattern is usually referred to as a shark fin pattern. Shark fin pattern can have many different causes. which have something in common. They are often associated with a high mortality rate. So we started with our differential diagnosis. We see that the first thing to exclude is, of course, an ischemic etiology, and indeed, shark fin sign is, in most of the cases, associated with an anterior myocardial infarction. In this case, actually, there is often a specularity, especially in the inferior lid, which was not the case in our patient. However, just to be sure, we performed an echocardiogram and troponin, and they were absolutely normal. So we were able to rule out this condition. The presence of a normal echocardiogram allows us also to rule out a Takotsubo syndrome. Takotsubo syndrome, which in very rare case can present itself as a shark fin sign, as we can see in this image. Once having ruled out the ischemic etiology, we thought about the Osborne wave. Osborne wave are usually associated with severe hypothermia. They indeed develop under 43 or 44 degrees Celsius, and they resemble a bit our ECG. Of course, they are not completely identical. Even in this case, we can see that there is an elevation of the J point and the ST segment elevation, which is, however, concave. This alteration usually completely resolve and normalize after 12 to 48 hours after the restoration of normal body temperature. So in our case, we immediately withhold cooling therapies, but after 1 day, the ECG abnormalities were unchanged. Of course, we all know that intracranial hypertension can itself cause ECG abnormalities. These are most often identified as a giant negative T wave with a prolongation of the QT interval. And it's actually in rare cases, especially from many years ago, there were reports describing the presence of ECG abnormalities, meaning ST segment elevation in patients with intracranial hypertension. Of course, this cause cannot be thus completely ruled out. However, the timing makes it quite unlikely. Indeed, we start seeing ECG abnormalities only after 7 days. The ECG abnormalities present in our case somewhat remind us of a Brugada-like pattern. Of course, this is not a typical Brugada pattern, which is often described in V1 to V3. And of course, there are a few reports of an inferior involvement. But of course, this was not the case, as in our patient, the ST segment and J point elevation was present throughout all the ECG lead. However, we have to take into consideration from the other side that propofol has been described to be one of the drugs that can elicit and enhance ECG abnormalities in Brugada patient, and indeed the administration of propofol in patients with Brugada syndrome has been associated with the development of malignant ventricular arrhythmias. We come now to our final and favorite diagnosis, propofol infusion syndrome. Propofol infusion syndrome is a quite rare condition, although maybe underdiagnosis. This is usually associated with a very high dosage of propofol, and this dosage of propofol are usually administered in patients with intracranial hypertension. Indeed, if we look in the literature, we see that most of the reports of propofol infusion syndrome are in young patients with intracranial hypertension. Also, the administration of catecholamine, as in our patient, is considered a risk factor. Propofol infusion syndrome is not just a syndrome characterized by ECG abnormalities, but it's indeed a systemic disease associated often with rhabdomyolysis and acidosis. Indeed, the ECG abnormalities often follow this systemic syndrome. One of the peculiarity of our case, as well as a few other reported in literature, is the fact that in our patient, the ECG abnormalities, developed before any systemic symptoms. Indeed, our patient had normal electrolyte, normal CK, and normal pH. And the other thing that we have to note is that ECG abnormalities always come before the development of ventricular arrhythmias. Thus, it is very important to promptly recognize this syndrome, as if we make a quick diagnosis and we are fast in withholding propofol, we can maybe avoid the development of life-threatening ventricular arrhythmias and sudden cardiac death. For what concerns the ECG criteria associated with Priest syndrome, there are actually no specific criteria, even because there are very few patients reported in literature. We can see from, for example, these two previous case reports that the usual abnormalities are always present throughout more or less all the ECG lead, and they are associated with a diffuse ST segment and J point elevation. So coming back to our patient, as said, echocardiogram and troponin were normal. We withhold cooling therapies, but nothing changed. And of course, we immediately withhold propofol too. And after 40 hours after the withhold of propofol, we see a normalization of the ST segment elevation. What we see now in the picture is typical abnormalities present in patients with intracranial hypertension, so giant negative T wave and long QT syndrome. Fortunately, the patient during the following days of hospitalization progressively improved, both from a neurological perspective and also from an ECG perspective, and she was indeed discharged after 30 days with a normal neurological condition and with a normal ECG. We, of course, tried to rule out Brugada syndrome. We performed a genetic test, which was negative. Of course, we wanted to perform also an Ashmanin test, but the patient refused. So our take-home messages, of course, in patient presenting with a shark fin sign, the first thing that we should immediately rule out is an anterior myocardial infarction, which is the most worrisome and the most common cause. And then we can start to take into consideration more rare entities like Takotsubo syndrome, Osborne wave, Brugada, and Priest syndrome. Specifically, it is very important to be aware of the existence of Priest syndrome, as a prompt diagnosis can really be a life-saving diagnosis, as if we manage to quickly withhold the propofol, then we are able to avoid the development of sudden cardiac arrhythmias. Sudden cardiac death. Thank you very much.
Thank you, Marco. It was really a nicely done presentation. Very well done. I'm first of all happy that you could save this patient. I mean, it's really, impressive, this ECG, and when, you said that the patient didn't experience any particular, ventricular arrhythmia, that is also very surprising. So, I mean, congratulations for the case and congratulations for the outcome. I have just a specific question, and I'm just curious to know also the opinion of Pedro on the case, and if you guys, hello Jeffrey, I mean, we will introduce you afterwards. If you have any comments, more than happy. Just, I'm curious to understand what is your, in your opinion, also the fact that, in this case, as you showed, other ECGs with this propofol infusion syndrome, also the P wave is kind of, flat, and you cannot really distinguish very well the P wave from the rest of the electrocardiogram, of the parts of the electrocardiogram. Do you think also, that that could be included in the criteria, in the ECG criteria, the absence of a recognizable sinus P wave? Or, I mean, you think this was just your case that went through this?
Well, I have to admit that from the ECG that I show, a P wave was not really clearly visible, but I think that was maybe more a coincidence, because looking at the other ECG traces and the monitor, the P wave was clear, and that's also the reason why we didn't consider like ventricular tachycardia among the differential diagnosis, as we can clearly see that there was an underlying sinus rhythm. So maybe it was just a coincidence from the tracing that I put in the slide.
Yes, Pedro, do you want to say something about that?
Yeah, a few comments, because this is a very interesting case, and a case, of course, very important to be seen by the residents, by the people that has maybe not had the chance to see these cases, because effectively the immediate recognition of this problem and stopping the propofol is the solution to the problem, because this is most likely a propofol induced syndrome without any doubt. Now, there are a couple of interesting things. The first thing is about this P wave. This is in the old literature called sinoventricular conduction. So there is a sinus rhythm, but you don't see the P wave. This is an electrocardiographic term, but is meant to tell that although there is sinus node activity, sometimes the conduction in the atrium can also be so abnormal at that time that actually you cannot see a P wave. The P wave is there, but you cannot see it simply because of the very low conduction that happens at that moment. So that's sinoventricular conduction. Another thing, if you look at your electrocardiogram, there is in lead V2 alternance of the T wave. If we can, don't know whether we can see the ECG, because
shall I share it?
Just a figure, the figure, the electrocardiogram. Okay, so you'll see that actually it's only in lead V2. Let's go back. Yes, okay, look at this. Here you'll see in lead V2 that actually the T wave, the final part of the T wave, is alternating. You see that? There is a negativity which is disappearing and then comes back and then back. Okay, now T wave alternance during sinus rhythm, this is defined already, something was defined by Carl Lewis in the first electrocardiograms that they recorded. You know that he was very disappointed that he did not get the Nobel Prize together with Einthoven, actually, because he was really, very, very fond of all of this. In any case, he described that a T-wave alternance during sinus rhythm actually is an indicative of a very severe, electrically, very severe disease heart. And what are you seeing here is indeed almost the final part. If you would not have stopped the propofol, I'm sure that this patient next minutes, next moments would have gone into severe ventricular arrhythmias. Now, what we see here again is that this is a phenotype, let's say. The causes, as you have said very nicely, and I think that the title of your paper, One Sign, Many Shadows, is excellent to illustrate that you have to look at the clinical situation before defining what actually is happening on the ECG. And I think that, to be honest, that this patient probably did not have Brugada syndrome, that, as you said, it is a propofol-induced syndrome. Now, there is one important question for me. This is a 19-year-old woman. What was the cause of the cerebral hemorrhage? It was at a rupture aneurysm or something like this?
There was a small berry aneurysm in the Wills circle.
So a congenital malformation, probably.
Yeah, it was more a vascular disease.
It was not related to any, let's say, any vascular problem or anything outside the cranium. I mean, it's not that we have a patient with...
Everything else was completely unremarkable.
Very good. Well, and I think that also very important is what you see once you recover, let's say, the ST elevation and comes to the negative T wave, the typical, then you see a prolonged QT interval that you do not see during the electrocardiogram during the propofol-induced syndrome. That's also important because, I think that for the differential diagnosis in relation, what was the major contributor here? I think it was, of course, the propofol, without any doubt. Very nice case and very important indeed to show that everybody knows that this is a life-threatening situation.
Thank you.
Very well. Thank you, Pedro. It's always nice to hear from you and give these hints of in electrocardiography that are really, really wonderful. So I'm going to go ahead with the presentation. So the next case, the next winner is Dr. Inbar Raber. And please, Inbar, it's your turn and for showing us the slides of your case. Thank you very much.
So my name is Inbar Raber. I'm a second-year general cardiology fellow at Beth Israel Deaconess Medical Center. I just want to say thank you to Dr. Grapsa and Dr. Sorgente for organizing the EKG challenge. as well as to Dr. Brugada and the other EKG challenge winners for joining for the discussion today. So our case is called a wide complex tachycardia in a young woman. And I'll preface by saying that we chose this particular case not because it was especially rare or uncommon, but rather because we felt that it was an important pattern for cardiologists to recognize and had some important EKG teaching points as well. So her case, she is a 27-year-old woman with history of anxiety who presents with several days of intermittent palpitations. On presentation to the emergency department, she has a heart rate of 80 beats per minute and a blood pressure of 155/78. She has no family history of sudden cardiac death and a normal echocardiogram. And on telemetry, she's noted to have short runs of a non-sustained wide complex tachycardia, and an electrocardiogram is obtained. And so this is her EKG. So she starts out in a sinus rhythm at 90 beats per minute, and then has a 19-beat run of a wide complex tachycardia, whose morphology I'll discuss a little bit more on a later slide. And we posed the question, what's your diagnosis based on this? Is it a supraventricular tachycardia with aberrancy, an SVT with pre-excitation, a moderator band VT, outflow tract VT, or vesicular VT? And so when thinking about a wide complex tachycardia, we typically think through a differential diagnosis that includes ventricular tachycardia, SVT with existing aberrancy, SVT with functional aberrancy, and SVT with pre-excitation. And when trying to differentiate between VT and SVT, we're aided by the Brugada criteria. So definitely a privilege to discuss the Brugada criteria with Professor Brugada on the line as well. And these are the criteria that we're all familiar with. So we look for an absence of an RS complex in the precordial leads, an R to S interval over 100 milliseconds in a precordial lead. We look for atrioventricular dissociation, and then morphology criteria for VT present in leads V1 or V2 and V6. And in terms of the morphologic criteria, if a patient has a right bundle branch block morphology, we look for a monophasic R or QR or RS in lead 1, which favors VT. A triphasic complex favors SVT. In lead V6, we look for R to S ratio less than 1, QS or QR, or a monophasic R, which favor VT, whereas a triphasic complex or an R to S ratio greater than 1 favors SVT. And then if the patient has a left bundle branch-like morphology, in V1, an R greater than 30 milliseconds, the time from onset of the QRS to nadir of the S greater than 60 milliseconds, or a notched S favors VT. And then finally in V6, a QR, QS favors VT, and a monophasic R favors SVT. And so in looking back at our EKG, we'll notice that there's a left bundle branch morphology with a dominant S wave in V1. And we can see that the QRS onset to the nadir of the S wave is greater than 60 milliseconds in V1 and V2. And we can also notice that there's 3-to-1 VA conduction. So all of these are signs that point to this being a ventricular tachycardia over an SVT. And then we'll also notice that there is an inferior axis with tall R waves in 2, 3, and AVF. And so once we've established the diagnosis of a ventricular tachycardia, the next step is to think about localization. And so the QRS morphology can be helpful as the bundle branch pattern is related to the sequence of activation of the LV and the RV. Left bundle branch block is present in virtually all right ventricular tachycardias, as well as left ventricular tachycardias that arise from the septum. Whether the axis is superior or inferior can help localize the VT. Superior axis VTs typically arise from the apical portion of the ventricle, whereas inferior axis VTs arise from the high basal areas of the heart. And so we included outflow tract, fascicular, and moderator band VT in our options. So for outflow tract VT, it typically appears as a left bundle branch morphology with an inferior axis. And it's the most common idiopathic ventricular tachycardia. It's caused by cyclic AMP-mediated triggered activity. And some of its treatment options include monitoring, catheter ablation, nodal agents, and antiarrhythmics. And I'll discuss treatment options more in a later slide as well. Fascicular VTs typically appear as a right bundle branch morphology and can either have a superior axis when arising from the posterior fascicle or an inferior axis when arising from the anterior fascicle. Similar to outflow tract VT, this is an idiopathic ventricular tachycardia whose first-line treatment is typically verapamil. And then lastly, moderator band VT. So this is typically a left bundle branch morphology. It can have either a superior or inferior axis, depending on where the moderator band inserts into the RV free wall. And unlike outflow tract and fascicular VT, so this is a pathologic VT which can instigate ventricular fibrillation. And so it's typically treated with ablation or antiarrhythmics. And so going back to our question with the left bundle branch block and the inferior axis, this is an outflow tract ventricular tachycardia. A few more points about outflow tract VT. It can arise from either the right or the left outflow tract. Traditionally, an earlier R-wave transition, such as in V2, can favor a left ventricular origin, but often this can only be confirmed with mapping in the electrophysiology lab. Outflow tract VT are caused by cyclic AMP-mediated trigger activity, which can be terminated with adenosine. And treatment of outflow tract VT can be deferred if the patient is asymptomatic and has infrequent ectopy. Frequent premature beats can place the patients at risk for cardiomyopathy, which is typically reversible. Catheter ablation is usually the recommended treatment over metoprolol or propafenone because of the effectiveness and low complication rates of the procedure. And lastly, RVOT VT can be a feature of arrhythmogenic right ventricular cardiomyopathy or ARVC. So it's important to assess patients for characteristics suggestive of ARVC, such as epsilon waves, T-wave inversions in V1 through V3, and a family history of sudden cardiac death. In terms of treatment for RVOT VT, this was a randomized study published in 2014, which compared the use of antiarrhythmics to catheter ablation. So they looked at metoprolol and propafenone. And they found that at a 1-year follow-up period, the rates of premature ventricular beats were much lower for the ablation group at about 19%, compared to 88% for the medication group. And so going back to our case, she was started on verapamil, 180 milligrams initially, and was discharged with a 2-week ambulatory EKG monitor. Ambulatory EKG monitor revealed frequent premature ventricular complexes at 32% and 18 runs of a non-sustained ventricular tachycardia. She continued to be symptomatic with palpitations. She was brought to the electrophysiology lab where her VT was mapped to the septal side of the RVOT and was successfully ablated. She had improvement in her symptoms and her PVC burden at a clinical follow-up of 2 months after the ablation. And so some of our conclusions: differentiating ventricular tachycardia from supraventricular tachycardia with aberrancy or pre-excitation is important to inform prognosis and treatment. Outflow tract VT is the most common type of idiopathic VT and is characterized on electrocardiogram by a left bundle branch morphology and inferior axis. Outflow tract VT can be monitored in asymptomatic patients with infrequent ectopy, and in symptomatic patients can be treated with ablation or antiarrhythmic medications. So once again, thank you so much for the opportunity.
Thank you, Inbar. It was really a great presentation, a great overview of how to distinguish this idiopathic ventricular tachycardia. And yes, I mean, I'm very happy that you mentioned something about the mechanism of these ventricular arrhythmias. Many times nowadays we are facing with more and more with electrophysiologists that are simply ablationists. And so we are actually forgetting, something that, of course, I think it's always important to start thinking about the mechanism behind these arrhythmias. And, you mentioned clearly that, in the majority of cases, these idiopathic VTs have a triggered mechanism behind. And this actually can help in identify which is the best medical treatment other than ablation, which, of course, will take care probably of the arrhythmia regardless of the mechanism behind. So thank you very much for doing this. And I would like to ask, Pedro, what is his opinion about that? I mean, how can, the current electrophysiologist can continue to search for mechanism rather than thinking only about ablation?
Thank you, Antonio. Well, I have to be very honest. I will say that I disagree a little bit with you about the medications, but I'll come back to that. Indeed, the understanding the mechanisms has brought us to the new technologies. We did not understand the mechanisms, for instance, of atrial fibrillation until Heiseger just started to put catheters in the left atrium and show that abnormal ectopic activity could be the trigger of atrial fibrillation. And nowadays we are ablating and treating successfully an arrhythmia that used to be a real problem, a very important problem for our patients. And so has been for many things. The Wolff-Parkinson-White syndrome, we started to ablate it at the moment that we understood that this was an accessory pathway. And now, for instance, for these idiopathic ventricular tachycardias, we are now understanding the mechanisms thanks to many studies, among others, the biopsies that were done in some patients that showed the mechanism of the cyclic AMP-mediated triggered activity that was in biopsies of actually the outflow tract of the right ventricle. That has been done in a very limited number of patients. But we understand the mechanism. But still the treatment, I believe that nowadays, to be honest, that antiarrhythmic drugs have not been very successful. And particularly when dealing with this very young population, if we have a curative or potentially curative treatment, I believe that we are really obliged to offer the best option first. And the best option, the only one that can cure these patients are not medications, but is ablation. Well, if you fail ablation, still you have the option of medications. But if you are cured, then the story is finished. Yeah? Now, let me just address a couple of things. First of all, I'm very happy that criteria of 30 years ago, in 91, we published this criteria that is still helpful to differentiate the mechanism of tachycardias. But I disagree with one thing you said, and it's actually this 3-to-1 VA conduction. Now, I don't know whether we can see the electrocardiogram again. Let's, if we can go to the first of the second slide, the one where you have the electrocardiogram. Because it is interesting, a 3-to-1 would mean that there will be this block of the third P wave. And here what we see is that we have 3 QRS complexes, and then we see something that looks like here, as you can see, a P wave. Now that would be, if you call like this, that would be a 1-to-3 conduction all the way around, because only one P wave would be conducted. But now I do not believe this is a retrograde P wave. Look, it looks positive to me. And if you measure, I have tried to do that on the screen, but it does not fit 100% because the patients have variations in the sinus rhythm. But actually, if you look at it, it seems that that could be simply the sinus rhythm going around. And here you see it again. You see here the final part that is going, well, anyway, it is dissociated, no doubt at all. And this excludes, of course, among other things, antidromic tachycardia over an accessory pathway, which had to be considered in this very young patient. But I would rather, measure that carefully, and I think that this is actually simply the sinus rhythm dissociated from this. And well, in terms of the frequency of this arrhythmia, as you said, this is very, very, very frequent in the young population. And just again to come to that point, because of the young age, I think that nowadays we can offer ablation really as a first option, just as a first option. Then the patient will decide, but I will not, I would certainly, on my table, I would put ablation next to antiarrhythmic drugs as a first option for this patient, Antonio. And you know that we are pretty successful in this arrhythmia at the present time.
Yeah, absolutely, Pedro. Of course, I mean, I'm happy, that you are actually offering ablation to your patients, because, of course, I mean, my question was not about the efficacy of the ablation that we know, fortunately, is very high in, the majority of arrhythmias nowadays. But, the thing is that sometimes, I mean, probably we are addressing these arrhythmias with medication that are not the right one. So, I mean, probably the mechanism will help to discover other medications or other, way of treating. And that's the reason why I'm always very fascinating about discovering mechanism of arrhythmias. But I mean, you're completely right. I mean, that in these kind of cases, ablation should be offered as a first option to these patients, because it's not absolutely, compatible with the long life with medication. This patient was very young. I understand that these arrhythmias can be sometimes transient, and so offering medication can also actually give a little bit of time to the disease, to settle down, like sometimes it happens. But I think, I agree with you that ablation should be also offered as a possible option. Okay, if anybody else has, contribution, thanks again, Inbar. Was really a very good interaction. I would introduce the last but not least winner of the ECG Challenge Competition, Dr. Jeffrey Smietana. Welcome. And so go ahead with the presentation. We already introduced you in the beginning.
So this was, my name's Jeffrey Smietana. I'm electrophysiologist at Temple. This was work conducted during my time as a fellow. This was an ECG submitted entitled Supraventricular Tachycardia in Search of an Underlying Mechanism. A pretty classic presentation. This is a 63-year-old woman with a past medical history of just hypertension. Came into the emergency department with 3 months worth of recurrent palpitations. A 12-lead ECG was obtained, demonstrating a narrow complex tachycardia. So not something infrequent. The question we asked is, what is the diagnosis? Sinus tachycardia, atrioventricular nodal reentrant tachycardia, AVNRT, atrioventricular reentrant tachycardia, AVRT, and atrial tachycardia, AT. This is the 12-lead electrocardiogram that was obtained. You can see that it's a narrow complex tachycardia. The differential diagnosis here is going to be similar to the questions that were question answers that were asked. The only thing that I may include would be a junctional tachycardia, and sometimes, in addition, for a regular narrow complex tachycardia, an atrial flutter that's conducting with a regular ratio. So the important thing to identify here is the relationship between the V and the A. So, typically for an SVT, you usually think about AVNRT. It's the most common, usually about 50 to 60%, AVRT 30%, and AT usually about 10% of cases. So if AVNRT, the odds are most likely just based on numbers. And if you look, the P waves here, you can see are kind of on the tail end of the QRS. So this is a short RP tachycardia, and the P waves are very narrow, which is kind of classic for what would be AVNRT. If you can imagine retrograde activation of the atrium kind of at the septum as it comes retrograde up the AV node, it's activating the left and the right atrium, creates these narrow P waves. And the VA interval typically in AVNRT is classically very short, always less than 70 milliseconds in typical slow fast AVNRT. And it usually falls within the QRS complex and can be seen sometimes at the terminal end of the QRS and sometimes referred to as a pseudo R prime. And if we had the sinus ECG, we would see that that's not present there. This could still be atrial tachycardia or ABRT, an AT coming from the septum with a very long PR. So the observation here that really kind of seals the deal is if you look, for example, here in V1, these red arrows, the P waves are intermittently absent, or not present, or visible on the ECG. You can see here highlighted in blue, I've pointed out the retrograde P waves, and then you can see where they're absent in red. And this is a kind of a key feature of this ECG because it kind of excludes most of the other possibilities. Sinus tachycardia, atrioventricular reentrant tachycardia using an accessory pathway, and atrial tachycardia would not be possible with intermittent, loss of an A, essentially VA dissociation. So it kind of leaves us with the only answer choice here is B, AV-NRT. So, why can't it be those other possibilities? Well, if you think about AV-RT, atrioventricular reentrant tachycardia, usually it involves an accessory pathway and a reentrant circuit that includes the atrium, the AV node, the ventricle, and then retrograde up the accessory pathway. That's orthodromic AV-RT. If the atrium was absent, that means that you don't have, the wave front propagating through the atrium. You essentially have block in the accessory pathway, and there's no way for the circuit to continue. So there's no way for the tachycardia to continue to perpetuate without the atrium being a component of the tachycardia. With atrial tachycardia or sinus tachycardia, you have a single focus here firing, and if you have an absent A or an A that doesn't exist, you're not going to have a subsequent QRS. Or if the atrial beat is perturbed in any way, the QRS will be perturbed. And this is kind of a simple, oversimplified version of the AV node. And this is typical slow, fast AV-NRT. And you can see here, if you travel down the slow pathway, you can activate the ventricle, and then it goes retrograde up the fast pathway, and the circuit is contained within the AV node. And activation of the atrium and even activation of the ventricle are passive. So you can have intermittent loss of the V with lower common pathway block. You can also have intermittent loss of the A if there's block within the upper common pathway. And there is some debate whether there's the existence of an upper common pathway because the activation of the atrium is kind of broad, and there's no anatomical or histologic evidence of an upper common pathway, but there are definitely reports of upper common pathway block, whether it be functional, and even reports of AV-NRT continuing during atrial fibrillation. So this is just a ladder diagram kind of demonstrating this. You have the dotted lines representing the slow pathway and activation. So that's antegrade activation down the slow pathway, and then up the fast pathway, down the slow, up the fast. And you can see that atrial activation and the ventricular activation are passive. So if you have block to the atrium, as demonstrated by the red arrow and in the ladder diagram, the tachycardia circuit is still able to continue. Couple other possibilities that weren't included answer choices, where you can also see AV dissociation in an SVT, will be a junctional tachycardia. And this is just demonstrated here, similar to an ectopic atrial focus, but this is occurring in the the His-Purkinje system somewhere in the vesicular system. And you can have block retrograde to VA here, and the tachycardia will still continue as it's not a critical component of a reentrant circuit. And this is, again, much rarer here, concealed nodal vesicular reentry, which is, again, another accessory pathway that inserts from the atrium right into the vesicular system. And if you get orthodromic reentry with a concealed nodal vesicular pathway, you can also have intermittent loss of the A, again, as it's not a critical component of the circuitry. So that's the electrocardiogram. Just wanted to kind of point out that a good, thorough examination of the ECG can't always, but many times can give us the best clues to kind of come up with the appropriate mechanism. And this patient underwent a slow pathway modification, and which was curative. Thank you.
Thank you very much, Dr. Smietana, about your presentation. It's very clear, and I think you remember me a little bit. The never-ending story about the necessity of the atrium in heavy NRT. I remember when I was in Boston. Dr. Josephson speaking about this, making lessons about. The mapping of the atrium during ABNRT, and the fascinating discussion against this hypothesis that Dr. Jackman was doing on the other side. And I'm just curious to know what Pedro thinks about these theories, about the theory about participation of the atrium in ABNRT. I think you were there where this discussion were happening, and I'm jealous about the fact that I couldn't be there at the time. So I'm just I want to gather you perhaps some nice stories about this eternal dilemma.
Well, yes. I think that's an excellent moment to honor the late Mark Josephson, one of the real superb guys in electrophysiology. We had a lot of discussions together, and we actually reported also that in some cases of AV nodal reentrant tachycardia, the atrium is not necessarily, because we showed that AV nodal reentrant tachycardia can continue in spite of atrial fibrillation in the atrium. So the atrium being fibrillating and the tachycardia continuing at the same rate, it was another argument for that. I actually took, the liberty to look for, the publication of Mark Josephson in 1976, because Jeffrey, you are really in a cathedral of electrophysiology in the University of Pennsylvania. And actually, Inbar is actually, if I do recall well, yes, indeed, Inbar is with Al Buxton, a good friend of mine also, who was a pupil of Mark Josephson. They were working together there. And you see here, actually, a very nice way, another way of showing this phenomenon that's published by Castor and Mark Josephson, Dr. Castor at that time. And is that they show that at the time of initiation of the tachycardia, you might initiate the AV nodal reentrant tachycardia without retrograde conduction to the atrium. And if you go and shorten the premature beat interval just a few milliseconds, then you actually will initiate the tachycardia in the classic way with retrograde conduction, because the AH interval, the conduction to the ventricles, becomes slower, and that allows the atrium to recover. Here, the atrium is refractory, and there is no conduction to the atrium, showing indeed, again, that this atrium is not necessary for the perpetuation of this, for the initiation in this case, and perpetuation of the tachycardia. Now, this is a very rare phenomenon. I have to be honest. This is something that you see if you search for it very carefully. So this is very nice to show that. But at the same time, we have to realize that this is something that normally you do not see during AV nodal reentrant tachycardia. Now let's, if I might ask, go again to the electrocardiogram, because there are two criteria, electrocardiographic criteria, that I would like to comment, which are unusual in this case, because actually they suggest another mechanism. So let's see the tachycardia. All right. Perfect. Okay. Now, you know that one of the criteria that has been reported in terms of differential diagnosis of the type of supraventricular tachycardia is alternance of the QRS complex. And if you look at lead V2, you see that during the tachycardia in lead V2, the height of the R wave alternates. Exactly. And this has been suggested as a criterion that would support the diagnosis of circus movement tachycardia using an accessory pathway. And you know that this has a certain specificity, a certain sensitivity, like anything in medicine. And particularly when the tachycardias were very fast, which is not the case here, that was very suggestive of circus moment tachycardia using an accessory pathway, which is not true in this case. Second, the other thing is the abnormal repolarization that we see here. This has also been shown to be, in young individuals at least, a criterion that suggests an accessory pathway because of two phenomena. One, the P wave, which is later actually after the QRS complex as compared to AV nodal reentrant tachycardia that can simulate ST depression. And the other one is actually because of the repolarization abnormalities that might appear during tachycardia if the patient has pre-excitation during sinus rhythm. So you have abnormal depolarization, and during the tachycardia, the abnormal depolarization of the pre-excitation disappears, and then you get this actually memory of the heart repolarization abnormality as a manifestation of the pre-excitation during sinus rhythm. Of course, here we're talking about a person of 64 years of age with hypertension. I don't know whether she had coronary artery disease. Normally, you know very well, in young individuals, this ST depression has no significance at all in terms of ischemia and is a manifestation of this P wave and repolarization abnormalities, usually as caused by a circus movement tachycardia using an accessory pathway. So this is a beautiful case. I really agree. I measured this also, and you have seen that this is a Movitz 2 retrograde Benkevac, type 8 to 7. Yeah. And this tells you a very important thing in terms of mechanisms also. Whatever this is located, this is a fast conducting pathway for sure. And this has Purkinje-like properties because Movitz 8 to 7, you'll never see that in any conducting tissue like AV nodal-like tissue. This is some tissue that is dependent on the sodium channel, not on the calcium channel. Very, very nice case. Beautiful, 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 without any doubt. Congratulations.
Thank you, Pedro. I mean, it's I'm without words just because how many things. I mean, we can still learn. You know, just reading ordinary ECGs. Sometimes we stress the fact that you know, electrocardiography should be recognized by artificial intelligence, but I wonder how all this information can be given by a computer. So thank you very much. I think all of you guys deserve this winning competition, to win the competition. I'm very happy, you know, to have met you, let's say, virtually in person. And, you know, congratulations to that, and continue to strive for the best, because I think, I mean, good electrocardiographists are always good cardiologists. So thank you very much. I don't know, Pedro, if you want to also say something to conclude this session. Was really
well, that simply that I enjoyed it very much, and indeed, I mean, I think that there is one important thing in medicine, and this is probably what distinguishes electrophysiologists and some cardiologists from the rest of the world, and is curiosity. Yeah, the curiosity is actually the basis for the advancement of science, and only electrophysiologists and electrocardiologists, you know, have the curiosity and the time, and spend the time, you know, measuring things and looking for these little details that actually explain the mechanisms of the arrhythmia of the patients. So I think that we are far, far in advance from the rest of the world, thanks to our curiosity, and keep on being curious. That's the most important thing. Thank you.
Thank you very much. Thank you very much to all.